Our laws as it pertains to substances are draconian and bizarre. The psychopaths start this way. He was an alcoholic because of social media and pornography, PTSD, love addiction, fentanyl and heroin. Ridiculous. I'm a doctor, for sake. Where the hell do you think I learned that? I'm just saying, you go to treatment before you kill people. I am a clinician. I observe things about these chemicals. Let's just deal with what's real. We used to get these calls on Loveline all the time. Educate adolescents and to prevent and to treat. If you have trouble you can't stop and you want to help stop it, I can help. I got a lot to say. I got a lot more to say.
And here we are, everybody. We are also out. Can you hear me okay here? My mic working? All right. Out on Clubhouse, where if you raise your hand, I'll bring you up to the podium. You can ask questions of our guest in just a moment. And of course, if you agree to do so, you'll be streaming out on YouTube, Twitch, Twitter, Facebook, all the platforms that are available. We are streaming. Today, we're bringing back Dr. Bruce Patterson. Any of you who has been with us through this pandemic will be aware that he has been an important voice, researcher in terms of understanding and developing treatments for long hauler syndrome, or whatever we're calling it now. He is the CEO of IncellDx, developing new precision medicine paradigms for predicting, identifying, and treating long COVID. Again, Dr. Patterson is the one of the leading forces behind COVIDlonghaulers.com. And of course, Dr. Patterson is also a researcher on the effect of viral pathogens. He was very active in the HIV epidemic and unraveling that puzzle. And
he's working together with Dr. Ram Yogendra, both of them. And Ram is on Clubhouse, so we're going to pull him up just so his voice can be heard. Because we couldn't have three people on the screen today.
Except Ram is not on Clubhouse yet, so hopefully he'll get there.
He said he is, but raise your hand, Ram.
There you are. Oh, you have a different thing now. Okay, I see you. Okay, see you with the hand up. And I will.
So just bring him up so he can.
Yeah, I'll bring you up in just a second here. And I want to introduce our second guest, who's a newcomer to the program. Dr. Eric Osgood is an internist, hospitalist, academic hospitalist, medical director of Mission Hospitals, St. Francis Medical Center. Oh goodness gracious, my page just went away here. Hold on. That was weird. All right, there we go. He doctorate from Tufts and medicine residency at Seton Hall. Dr. Osgood and Dr. Patterson, welcome to the program.
Thank you, Dr. Drew.
There you are.
To be here.
Good to see you guys. And let's bring our friend Dr. Yo in from the Clubhouse as well. So we have a lot of voices here today. Dr. Yo, how you doing, buddy?
Dr. Drew. Good seeing you. Good hearing from you again.
Get it on. Ram is an anesthesiologist who's been very active in, how shall I describe your role with the COVID long haulers? Are you a founder officially?
I guess so. Me
Yeah.
and Dr. Patterson, Dr. Parikh, we're the co-founders and I guess co-medical directors, right, Bruce? And
that's right.
We've recruited 11 physicians. Dr. Osgood, one of them. We got 3 clinical nurses. And tomorrow is our first day where we are doing our first telemed consultations in Europe, starting with the Spanish patients.
Wow.
So very excited about that.
Very interesting. So where should we start the update? Last time we talked to you guys, we were talking about CCR5 inhibition. We were speculating about statins. Where should we go? How should we start this conversation, Ram?
Yeah, I think, there's a lot, we've now treated or actively treating over 2,000 patients in the United States. We've got over 12,000 patients registered in the United States in the program, and there are various stages, whether getting lab work, having gotten lab work, fighting for a telemedicine consultation with our team. So we're really, really excited about that. And one of the things that we are starting to do is really understand long COVID, what exactly it is, and where more research and more answers need to come from. One of the things is, I think in clinical medicine, and you probably agree with this, Dr. Drew, is sometimes you think there's a diagnosis and you jump into it, and then you start realizing there are other issues taking place, and there's no like magic drug or magic potion or this magic bullet or whatever you want to call it in clinical medicine. So we are now Dr. Patterson and I and our team over 12 months now. We've been researching this. Two papers. I think the second one, I think Bruce will mention a little bit about it. It's kind of almost done with the peer review, so we're super excited about that. And one of the things we want to show is, again, we're off-labeling and repurposing things. It's sort of looking at tools in the toolbox that we have. Mm-hmm. And one of the things we want to do is to be able to study and put this in a randomized controlled trial and do some clinical trials. And this is where Dr. Osgood has a lot of experience. I'm super excited about him on the team. He's so instrumental in that. Where what we want to do is to show what we're seeing clinically is that we can show this in a study design and control for all the other factors. And one of the difficult things in medicine is if you don't know what you're studying,
right? You
don't know, you can't define the parameters.
Well, right.
What's a trial like?
Yeah, I think you are swimming in the messy waters of a syndrome as opposed to a diagnosis, right? And you're trying to nail it down to a diagnosis, meaning a common physiology, a common presentation, but it's been such a new syndrome to have developed, you're still swimming in the syndrome waters. Dr. Osgood, how did you get involved with this group?
So I ended up meeting up with Ram. How did you and I start first talking? I think we did a podcast together when we really hit it off, and I think we had a lot in common as far as how we approach disease and our clinical approach, our clinical thinking. Yeah. And at one point, he and Bruce reached out to me to see if I wanted to join the Chronic COVID Treatment Center, start doing some telemedicine with them. So that worked out well. I've been working with them since about July. And then we've been talking more and more about how we really need to do a clinical trial, a proper, randomized, blinded, controlled trial, without which you're not really going to get buy-in from the general medical community, and you can never really know if your intervention is responsible for your patient improvement or if it's just this is the natural history of that patient's disease, is it the placebo effect, what have you. Yet there are obviously going to be a lot of challenges when you're in that those syndrome waters, as you put it, and you don't have a really clear definition and parameters. So that's where we kind of brainstormed, and I came up with a kind of a novel idea of how we could approach such a trial, which I'm happy to talk about tonight.
Please, let's hear it. Let's do it. I'm going to get to Bruce to give me the whole. Bruce, I'm going to have you bring me up to the present, but I first want to hear from these two guys, and then I'll fill in the gaps, as they say. But go ahead, Dr. Osgood.
A very proud moment for me, where I can sit back and let the team talk for us. As Ram said, we've grown 3 physicians to over 11. We've now launched in the EU. We're up to 3 clinical coordinators. We're going to continue to expand throughout Mexico, Brazil, LATAM, and as much of the world as we can. So listen, I'm sitting back here like the proud father listening to everybody talk about the program. But I just wanted to add that Eric's design of this trial was really quite innovative, because, as I said at the International COVID Summit in Rome in September, this virus is a chameleon. And I'll tell you, every single patient that we've spoken to has a different story, different symptoms, what have you. And I think one of the biggest problems in COVID with getting treatments approved, not to mention vaccines, getting treatments approved is having a properly matched placebo group. I mean, when everybody's different, it's virtually impossible to have a placebo that's matched, who doesn't get the treatment, who's in a similar boat, so to speak. So I think that's been incredibly difficult. I've never seen anything like it in medicine, where that situation has arisen, that the patients are so incredibly different that you can't match them. And I think Eric's design has taken that into account, and will be the first CCR5 antagonist trial with statins, of course, that takes into account biomarkers and matching patients appropriately. So I just wanted to add that in, and I'm happy to let Eric expound on that.
Yeah, Eric, I think I'm hearing Dr. Patterson say that rather than look at the clinical presentation, you're matching with biomarkers. Is that how this is going to work?
Somewhat. So a little bit of my background after I graduated medical school, before I did residency, I spent some time in the pain clinical research world, basically phase 2, so proof of concept trials in the chronic pain world, and also doing like psychometrics and outcomes, and really trying to best design trials that are not going to fail. So we're really looking at the construct of the phenomenon of clinical trial failure, specifically in chronic pain. Chronic pain is a very difficult condition to study because a lot of the study drugs are only going to work on maybe 30 or so percentage of that particular disease population, and then it is so prone to the placebo effect, as well as to people maybe not being that precise or accurate in the way that they report. And so there is a need often to do enriched designs or enriched enrollment designs in order to better demonstrate proof of concept. And one of the things we really focused on was recognizing that seemingly homogeneous and sort of monolithic conditions are often consisting of subgroups and subclassifications based on sort of the mechanistic input of disease. So take something like painful osteoarthritis of the knee. One might think of that as a pretty simple monolithic condition where you have degenerative loss of cartilage, and you have the subchondral osseous tissue, which is heavily innervated, touching it, bone on bone, and you have pain, and it's normal nociception. When it turns out that there's very little concordance between radiographic severity and pain, and it turns out that there's patients with peripheral sensitization, there's patients with windup, there's patients with loss of normal diffuse noxious inhibitory control, central sensitization, and these different mechanisms of pain have very different sort of potential pharmacological targets, where if you don't include the right patients, you're not going to see any benefit. And so, when I started looking at COVID-19 and being a hospitalist in the hospital, seeing how this disease presented, and then later getting involved with chronic COVID, it became pretty apparent to me, and I developed a pretty strong hunch that we were treating likely a very heterogeneous condition that affects different people differently and has different, pathophysiological inputs as one condition. And I think that's led to a lot of the clinical trials being all over the place. Like, does tocilizumab work or it doesn't work? Does this drug work? Does this drug not work? And I think it's because what we will ultimately find out, what my hunch is, that there are probably multiple subtypes of severe COVID-19, predominated by different pathophysiological mechanisms. And I think that's where I really found a connection with the way that Bruce Patterson is approaching this disease, because he's doing that both in long haul and in acute COVID. So when it comes to COVID long haul disease, when you look at biomarkers, not everyone's the same. You have different forms of this, different ways you can land on the long haul index with different types of biomarkers that will respond to different types of pharmacology. So I looked back and I drew upon my experience in sort of the pain research world and found a lot of parallels to some of the challenges we might have in trying to actually study this in a randomized trial, where if we take sort of a traditional parallel arm randomized trial and try to put two groups together, likely the statistical power is going to be eroded by the fact that your effect is probably going to be overwhelmed by the placebo effect in the placebo group. You're going to have maybe only 30-40% of people in your active treatment group who would even respond to your treatment if it does work, and therefore, without doing a massively powered study with a huge sample size, you're going to likely to have failure. And so one of the clinical trial designs that often gets used in the pain world is something called the Enriched Enrollment Randomized Withdrawal ERW study design, which I don't know, Dr. Drew, if you've heard of that.
No, tell us.
Yeah, so this is where you take sort of a predefined subpopulation that you're interested in the disease model. So traditionally it would be chronic pain. Here it's going to be COVID-19, and we're specifically interested in patients with COVID-19 registering on the long haul index with a certain profile, such as elevations in CCL5 rantes, soluble CD40 ligand, interleukin 8, interleukin 6, low CSL4, what have you. And we're going to start them off in an initial open label phase where the entire study population knows that they're getting the study intervention. And what you do is, after sort of a defined study period, you look at patients who start to develop a clinical response and actually start to feel better. Those patients then make it into the next phase of the study, where they are then randomized to either continue on active treatment or go off onto a matched placebo. And what you're looking at is sort of a delta, an effect size between do those patients in the active treatment arm continue to go on to do well and improve? Do those who then go on to the placebo go on to do worse? And we're going to look at, we still have to decide on what our primary endpoint is going to be. Of course, we're going to look at different sort of validated scales for different symptoms, composite endpoints of activity and pain. Look at accelerometry, and of course, we're going to look at biomarkers to try to further validate. And of course, the weakness of this design is going to be generalizability. Like, what about the patients that don't get better in that open label? The benefit is that I think it has the best chance to generate proof of concept, so that we can show an actual clinical effect in a properly randomized and placebo-controlled trial, to then go on and potentially do further studies that are larger.
Right. It's not the absolute best design, but it's a good design for mandating further study or suggesting further study. Bruce, now you're nodding.
Mm-hmm.
Especially for
this type of, a heterogeneous group like this. I mean, Eric's right. I mean, with doing a standard parallel study, then you're guessing at what your sample size calculation should be, because there's so many differences. There could be, 8 kind of sub-phenotypes, if you will, that may have nothing to do with one another. And so I think this really does have the best chance of succeeding using some of the outputs that and outcomes that the NIH has already mandated for potential long hauler studies, which we have.
And do we have any kind of standardized criteria for long hauler yet?
Well, again, I think that's our published work that generated the long hauler index that came out in Frontiers in Immunology. I think that was a good start. I think actually what came out of that paper was kind of 2 things that we look for at the Chronic COVID Treatment Center, and that is, number one, the long hauler index, which is really a composite of biomarkers that sets you apart from acute COVID, normal individuals, et cetera. And in a moment, I'll comment on other similar diseases. And then of course, in addition to that, there's been this recurring pattern in our panel that suggests vascular inflammation. And, the vascular inflammation is characterized by, 4 different markers and that are separate from the long hauler index. And then, about 8 months ago, we asked, well, why is there vascular inflammation in long COVID? And that's when we started investigating, and we found persistence of the COVID S1 protein in monocytes in the absence of replicating virus in those cells. In fact, we did whole genome sequencing to prove that there was no full-length RNA or RNA that was capable of making virus, but it was persistence of protein, and we used proteomics to really define that. And we've used that, on Lyme, fibromyalgia, ME/CFS, and we're just about to submit an article that shows the similarities in these diseases, which have been actually lumped together because they have similar symptoms: fatigue, exercise intolerance, brain fog, etc. So there was always this question, 6 to 8 months ago, well, are they the same thing? What are the similarities? Well, when we used machine learning and AI to look at the differences, they are indeed different, but if you use a single algorithm to say, are they long haulers or non-long haulers, all of these register as long haulers. If you use the second algorithm, which is of all the inflammation, what's called a severity score, that's where you separate acute COVID, long COVID, post-vaccination long haulers, ME/CFS, fibromyalgia, etc. So we're very excited about looking into the pathogenesis of all those diseases that had similar symptoms, but now we're finding that there are some similarities amongst the differences in the immune system.
Go a little deeper into that sorting. Explain what the differences are, if you can.
So, I wish I had the figure that I could pull up where we overlay. So we have on one axis, the y-axis, we have the severity score. On the x-axis, we have the long hauler index. which are made up of different composites of these immune biomarkers called cytokines or chemokines. And the severity index, which we use in acute COVID, which says how severe is the disease and are you going to become severe, uses more or less like 6 or 7 of the 14 biomarkers we have in the panel. And then the long hauler index is made up of 3. And for instance, ME/CFS, chronic fatigue syndrome, and post-vaccination long haulers, which are patients who've never had COVID, who receive the vaccine and develop long hauler type symptoms. And again, this population is very rare. It's a very rare side effect of vaccines. We are absolutely pro vaccine, but they do develop these immunologic abnormalities that resemble chronic fatigue syndrome. And then if you overlay ME/CFS with true long haulers, they actually have higher long hauler indices than even long haulers, which means they have a higher level of what we call type 1 cytokines, interleukin 2 and interferon gamma. Yet they all kind of register as non-normal and non-acute COVID. So again, we'll be explaining a lot more in an upcoming publication, but it's fascinating to see that these diseases that have very common symptoms also have some commonality in terms of their immunologic abnormalities.
Which makes sense. Do you have a sort of a hypothesis in your head about what the physiology is here? Do you have like a sketch or a favored kind of idea?
Well, when we looked into the literature, and again, this is in our paper that should be out here pretty soon after peer review, we found that in post-Lyme, it's very common for the cell wall of the Borrelia bacteria, Borrelia burgdorferi, which is the best name in microbiology, is actually phagocytized or engulfed like Pac-Man by these monocytes that engulf the S1 proteins in long COVID. Mm-hmm. And then of course, we also showed in this paper that that these cells traffic all over the body, including through the blood-brain barrier, and they cause blood vessel inflammation because why? They bind to the blood vessels through another pathway called fractalkine. The exact same mechanism seems to be at play in post-Lyme. And these cells, as you know, also carry Zika virus, dengue fever virus, and the intermediate monocytes are infectable by HIV. And then we showed in 2009 that these cells were infectable by hepatitis C. So they are really a wastebasket for dying cells and cells that may contain viruses. And then they process these proteins and either express them or carry them around the body and cause inflammation. So it's really quite amazing that the body is capable of doing that in the absence at times of replicating pathogen, which may be totally new innovation. And
hope you don't mind a bunch of basic questions here. I'm assuming these monocytes don't live forever, right? I mean, so why do they continue to have an effect, or is that strictly the life duration of a monocyte that they have that effect?
Actually, they have a very short lifespan, on the order of a week. But when they're presenting antigen and carrying antigen, it blocks this senescence program so that they don't die. But if you keep them from doing what they're supposed to be doing, which is in the case of non-classical monocytes, binding to vascular epithelium through statins, they die off. And if we follow serially S1 containing monocytes in long haulers following therapy with CCR5 antagonists and statins, it goes down. It goes down with therapy over time, and it's accompanied by improvement in symptoms.
It's been pretty remarkable to watch that, though.
The drop in the monocytes and the improvement.
Mm-hmm.
Yeah, the clinical improvement since I joined the practice, and actually seeing people, and a lot of times I'll follow up and I'll see they presented months and months ago, they're all their cytokines are elevated, they're feeling terrible, and then they'll be in follow up. They did, a course of CCR5 antagonist, statin, maybe a brief course of low dose steroid or another, immunomodulator or two, and then you see them in their labs largely normalized. They're feeling better. They can focus and concentrate. Generally not back to 100%, but just markedly different. And so it's been very been fascinating. And then actually, since I've been in the practice longer, I've actually got new patients who I've now followed for months. And then again, you start to see them. You see the biomarkers improve. You see the clinical picture improve. It's been very rewarding to be a part of that. And so, getting a chance to now put that into a clinical trial we're very excited about it.
So it's a big deal. What are you using for the CCR5 inhibitor?
We're using a drug called Maraviroc, which is a drug hazard. Maraviroc or Cellzentry.
Yeah.
And in fact,
you guys were messing with that early on. You'd noticed something with that, or a signal with that. So that doesn't surprise me. And once again, what is it the monocytes are doing normally when they bind to the endothelium? What was the purpose of that?
It's really quite amazing. The non-classical monocytes express this receptor for fractalkine. Their main job is to patrol the vascular endothelium for inflammation, and in fact, now all of a sudden they're carrying something that induces even more inflammation. And what was really interesting in going through the literature on the latest paper was that when the non-classical monocytes bind to the endothelium, they release type 1 cytokines, interleukin-2 and interferon gamma. Well, guess what? That's the numerator on the long hauler index discovered by computer. So it's very satisfying to see, at least this mechanism coming together. And by virtue of the fact that these patients have responded to therapy directed at that mechanism, at least gives us some great confidence that indeed is a major mechanism of long COVID. And as Eric said, to see these people go from being bedridden to 85, 90%, 95% better has been absolutely remarkable. And of course, if they have this inflammation affects nerves. Sometimes nerves take a little bit longer to recover, but to see them going about their normal lives, exercising. We've had several in our program now. All of a sudden, they're like climbing mountains and going on hikes and playing with their kids and running 3 miles. I had one gentleman told me on telemedicine a couple of weeks ago. He was a little bit frustrated. He was pumping iron again. But he can only pump iron 3 days a week instead of 6 days a week. And I said, "Hey, Arnold, So, and he looked great.
Ram sent over a graph. Did you see that, Drew?
No, show me.
Can you put it up? Yeah,
on my
we're going to show it.
Put it up. Let's see what Ram sent us a graph of. Oh, this is the scatter.
Oh, yeah.
Ram, this is the long hauler index versus severity scale. These are the different syndromes and how they shake out. Right?
That's right.
Ram, you put yourself on mute again. Do it the other way. There you go. Go ahead.
There we go.
Yeah.
So that's the scatter plot that Dr. Patterson was referring to. We just sent it over a couple of days ago. I think the dark blue, right, Bruce, are the ME/CFS patients.
Define the ME/CFS for people.
So again, it's basically chronic fatigue syndrome. It's long thought to be caused by the chronic herpes family viruses, EBV, CMV, varicella, herpes simplex, HHV6, etc. But the hallmark is fatigue, brain fog, shortness of breath at times, exertional malaise, etc., just like a typical long hauler. So what you see is from our paper that's about to come out in yellow, which is the paper that already came out in yellow, which is the yellow is true COVID long haulers. The red are the red dots are the post-vaccination patients who never had COVID, who have long hauler symptoms after 3 or 4 months. On the far left, it's hard to see to the left of the vertical dotted line, but that's where the acute COVID patients lie. And obviously, the higher up they are, the more severe their immune systems are. And then, of course, in the lower dotted line in the lower left-hand corner are a bunch of normals and some mild to moderate acute COVID. So it's really fascinating how, these different aspects of not only COVID, but post-pathogen immune disorders are really separating themselves out. They're similar, as we said, in terms of the fact that they would register, if you just did long hauler index, they would register as a long hauler. But using the two algorithms, you can see that the true COVID long haulers have a higher degree of inflammation than the post-vax long haulers and the ME/CFS. And indeed, the post-vaccination long haulers, 2 to 4 weeks of therapy, maybe 6 at the outset, they respond very, very well, very quickly. COVID long haulers take a little bit longer, 4 to 8 weeks, maybe some out to 12. And so there is a difference in the response. And the ME/CFS is that those patients, which may be a completely different etiology, in other words, not involving S1, also respond to Maraviroc and statins. So, focusing on precision medicine and treating the immune abnormality, and then having that accompanied by symptomatic relief has been really gratifying, and probably the most gratifying part of the program. And, it's something that we continue to expand upon. Fibromyalgia will be added to this list, and we'll probably be looking at some point some of the autoimmune diseases.
Interesting. So I have a feeling this research is going to open up a bigger topic eventually, in that the lay sort of world is awash with descriptions of inflammation being an important part of health. And I've for a long time thought that what people were really talking about was vascular inflammation of some type, some endothelial something, because we were not talking about synovial attack by neutrophils. We're talking about some sort of low level. And I've had my eye on the fact that the lipid system, particularly the apolipoprotein system, and insulin tended to figure in this as well, seemed to be something that added to this, whatever this thing is you guys are starting to look at, this endothelial, what should we call it? Do we have a name for it yet? Endothelial inflammation? You said vascular inflammation. I don't think that's specific enough, because it sounds like a vasculitis, but that's not what this is. What is it?
Endothelitis, we've been using that term. Endothelitis, we've been using that term.
Okay. But certain genetic subsites, apolipoprotein metabolism, the effect of monocytes on laying down some of that inflammatory, oxidized material. This is an important area of health. It's not a surprise to me that the statin would figure into this. How do you think that's working?
Listen, I think Ram will agree, and probably I think this is a little bit before Eric's time, but we added a statin into our program. I would say, February, March of 21, and it was a real game changer. I mean, the COVID long haulers, they got better quicker. They got, the extent to which they got better was greater, and I think it all had to do with the fact that statins are instrumental in reducing vascular inflammation through this fractalkine pathway, which I think that's something we're also looking at to answer the question: why do some people become long haulers? Well, you know what? Just like other chemokine receptors, fractalkine receptors have gene polymorphisms, which are hereditary. Mm-hmm. They express different levels of receptors, much like a CCR5 receptor or other receptors. So they're looking into that as a mechanism. For instance, if you had some sort of defective fractalkine receptor, maybe you don't get vascular inflammation. You're protected from becoming a long hauler or something, or a post-Lyme, for instance. So we're just at the tip of the iceberg in really identifying how proteins can cause immunologic disease. And, I remember probably 10, 15 years ago when the first pan called gene chips, which had all 2,000 genes on them, which we used at Stanford, developed by UCSF. We used it to screen patients. We had no idea where to start. You couldn't validate it ever for clinical use because you can't validate every 2,000 targets. But we used it to steer us in the direction of FDA-approved tests. And it was amazing what we found. But the fact is, during that era, and that was the genomics era, everyone just slapped everything on the gene chip. I don't know what's going on. I'm going to put it on the gene chip. You know what? A lot of that was driven by the HIV pandemic. So one thing, having lived through now 4, 5 pandemics and been involved in the research, what I've really noticed is HIV drove the molecular revolution in medicine and came up with great approaches to cancer, where everything is precision medicine in cancer. You don't get a drug until they know that drug's going to work on you. And then I think COVID is really going to introduce proteomics and immunology into our daily lives in medicine, much like HIV introduced the molecular revolution. So we're getting ready.
And cytokines as biomarkers. That's the other thing. That's the thing that immediately started.
Absolutely, immune cell subsets, cytokines, all of it, and eventually we'll be able to, put all of that into machine learning and come up with even more signatures of disease that are immune mediated.
Ram, is that you?
Echo what Dr. Patterson mentioned about the fractalkine. That truly was a game changer or for many patients. It's very interesting. There's some patients that are contacting us from overseas, and they're long haulers or ones that are just having some post-vaccine symptoms, some persistent symptoms after the vaccine. And it's very interesting is because they haven't gotten any lab work done or they're in a different country. A lot of times the doctors will reach out to me and I just tell them, just start them on a statin, a very low dose, pravastatin or atorvastatin. And while it may not get them, completely resolved most of their issues, they do notice almost within a week some dramatic improvement in symptoms, especially the peripheral neuropathy. And the mechanism is, if you look at the textbooks on of how these non-classical monocytes are binding, and as Dr. Patterson and Dr. Osgood mentioned about the fractalkine receptors, it looks like Velcro. And they almost stick like when I remember looking at this going, this looks like Velcro to me. And the way I describe it to my physician colleagues and especially to the patients so they understand what's going on, it's almost like putting a piece of paper between Velcro. And what happens? It doesn't stick. And these non-classical monocytes, another thing I explain to the patients and the physicians is that I look at it as garbage trucks. And they're garbage trucks with garbage inside of it. And if you put garbage sitting in a garbage truck for 6 months or 12 months or 18 months, what's going to happen?
It goes
They're
bad.
going to smell. Yeah, it's going to go bad. You walk by and go, oh my God, it smells like crap. And the cytokine, the immune panel actually detects the smell, and the long haul index, it's almost like it's got this specific type of stench inside of it. It's like rotting eggs and, dead rabbits or whatever is in there. And you go, oh, that's what it is. Whereas then there's a different immune pattern, let's say from ME/CFS or some other pathology that we can then detect and use machine learning to identify that quote unquote smell. And the way I explain it is that our goal is to prevent the immune cells from sticking and then to immunomodulate and reset the immune system, because there is a dysfunction of the entire immune system taking place here, and that's the overall goal of the treatment.
It sounds like you also want those monocytes to die out. They get their senescence back in in gear.
Yeah.
It's where the CCR5 signaling is just, like Bruce and I have been talking about on your show and many other podcasts. It literally is the quarterback. You knock it out. It's another thing I explain to patients, Drew, is like it's almost like if you were on a street fight, like you are on First and Main Street, and you are about to get your butt kicked by someone. So what you do is you text Susan, you text a couple other people, and we're like, hey, I need some help. So all your friends come in, like maybe Susan comes in with like a bazooka, or Caleb is coming in with like a pocket knife.
I like machetes.
Machetes, right? Susan comes with a machete.
So it's a local favorite.
Well, I don't know what you guys are doing over in Pasadena, but
it's just Los Angeles generally.
Yeah. Well, so all of them come to this fight, and now this one little fight between you and this other person has gotten worse, and that's really what takes place in inflammation. What a drug like Maravirac does, it blocks the text messages from being sent out. So that text message you sent to Susan, she doesn't come. But more importantly, is that Susan doesn't bring the machete to the fight. So this is that whole downstream effect. Because now, not only are we blocking CCR5, you're knocking out the quarterback, you're knocking out the wide receiver, you're knocking out the running back. So it has this dramatic effect also on the vascular markers or the vascular inflammation that's taking place and some of these inflammatory signals. And then that's where you're able to decrease the inflammation and then, again, undergo apoptosis or programmed cell death of these non-classical monocytes.
Which is, you want them out. But let me ask this. I'm going to ask a couple of pushback questions. One was, Ron, when we first got to know you, you were talking about CCR5 as it pertained to leronlimab, right?
Yes.
Is it possible that the availability heuristic cognitive distortion is affecting where you guys are looking? And you had already, in other words, did you already have a predilection to look at the CCR5 system because of your interest in leronlimab? It just seems weirdly coincidental to me that we have leronlimab and now we have Maravirac, and it's both, just so happened that this turned out to be a very important piece of it. Or is it just that this was a very important piece of the cytokine physiology that you were picking up a signal on and looking at?
Yeah, I started studying CCR5 in the mid-1990s when it was a co-receptor for HIV, and have been working on it ever since. We were the first ones to identify CCR5, for instance, in the female genital tract as a parameter for HIV transmission. And so it's been, and then also looking at CCR5 on the variety of different immune cells, effector T cells, monocytes, T regulatory cells, which shut off the immune system. So it's been, yes, it's been a pet of mine, but it's been a pet of mine since 1996, right? So it really happened, and actually someone's writing about this. When I was in China the first week in January, I was there to talk about the immune system and some immune diagnostics that we had developed for CAR T therapy in cancer. When we started talking about the, quote, immune virus that was coming out of Wuhan. Well, interesting story. I was about to go to Wuhan to visit a customer of IncellDx's the following week, which would be the second week in January. And they basically said, don't come, we're shutting down. And then that precipitated even more discussion. And when I looked at some of the data from this, quote, immune virus, and then looked at some of the cells and plasma myself, that's when we saw this predominance of CCL5 or RANTES, in addition to elevated IL-6, in addition to elevated VEGF. And, it was a natural, well, CCL5 and RANTES is elevated. Let's block it with CCR5, right? Which, I was involved in some of the early studies of Maravirac and Vicrevirac, which was Schering-Plough or Merck's drug, and Icravirac, which was GSK's. This was in the early 2000s when we were doing assays for the other CCR5 antagonists. So it was something that was just like, oh, wow, these three cytokines, CCL5, IL-6, and TNF-alpha, are elevated. That's just a setup for a CCR5 antagonist. And yeah, it happened. We had one that was was right there, leronlimab that was, going into clinical studies. We knew Maraviroc was around. We could always get that if we wanted to. That's where it all started, basically, was in China. Think about it. So
it's that it is an important piece of the system, and it's just coincidence, serendipity that you happen to live there.
A leading physician at a very, very prestigious university say, why would you use a CCR5 antagonist? They're immunosuppressive. And this is a viral infection.
Mm-hmm.
I said, excuse me, they're not immunosuppressive. They're immune modulatory. And that is the beauty of using CCR5 antagonists instead of, potentially dexamethasone or other steroids, is that they aren't immunosuppressive. And in fact, they correct immune exhaustion. And, that's why I think this is the next big wave in inflammation, because we can actually modify the immune system without making you susceptible to other bacteria or fungi or some of the other things that just, steroid blasting people with is going to make you susceptible. And that's my big fear in the hospitals. When I get called from someone with acute COVID, which I have a lot with Delta lately, and I said, I know they're on dexamethasone. I said, that's personally, I don't think that's doing them any good. And I push for Maraviroc and statins because they're both FDA approved. And you know what?
Even in acute COVID, in acute COVID.
Oh yeah, why not? It's pathogenically. I mean, the cytokines that are elevated would respond to that combination. And so I always lose the Maraviroc battle. Although some patients, if they've ground it up and put it down NG tubes. But at the end of the day, I can at least get them on the statin. And there's actually a big paper that came out, I think, from Mass General, showing the efficacy of just statins in acute COVID. Now, there's a safe and effective and approach to acute COVID that has very few side effects.
What kind of any statin, and what kind of dosing?
It doesn't take a lot. We use 10 to 20 milligrams of statins. We're not trying to lower a cholesterol from 400 to 180. So it really doesn't take a lot to see a profound effect on the cytokine profiles.
I have to take a quick break here, but I want to ask you one other quick question. Last time we talked, you were toying around with the idea of sort of inflammation of the central nervous system, the elevation of the VEGF, and what happened to that little theory? Is that still part of what's going on, or was that just an epiphenomenon that doesn't seem that important?
No, I mean, the fact is, when you talk about blood vessel inflammation and you talk about cells, that's what's so interesting about monocytes. I mean, you have this diversity of symptoms. It's not focal like a rheumatoid arthritis, where you could say, well, I got to get to the drug to the joint, right? It's everywhere. And that just smells of a vascular type of inflammation. And yes, absolutely. Because what's key is when these non-classical monocytes bind to endothelium, they also increase VEGF, which is interesting, which causes peripheral neuropathies, which long COVID patients have a lot. And it causes vasodilatation. Vasodilatation, what does it cause? Headaches and migraines and tinnitus. So when you correct that, that's when you see a lot of that brain, and they say, oh, I have this pressure in my head. I've had so many patients, this is the call sign for long COVID. And when someone goes like that, you need a long hauler index.
True. I do
right?
Kind of like, I felt the fog. I felt it more in here, like the fog.
You have long COVID. No questions asked, because they feel this pressure, and the pressure obviously from vasodilatation, and then the headaches, and then the migraines, and when you relieve the inflammation, a lot of it just goes away. So
it's like the Levine sign of long COVID.
Right. Or it's
yeah.
So, okay, guys, I'm going to take a quick break here. This is a fascinating conversation. I've learned a ton already. And
I didn't get the joke.
there are things you do that are classical moves like and this and this, and in medicine they each have their own name, and now we have the long COVID sign, which will be the Patterson sign. So okay,
I get it now.
So thank you. We'll take a little break. Be right back with more of this after this. I want to give a shout out to our good friends at Blue Mics. If you've heard my voice on this show anytime over the past year, including right now, you've been listening to Blue microphones. And let me tell you, after more than 30 years in broadcasting, I don't think I have ever sounded better. But you don't need to be a pro or have a fancy studio to benefit from a quality mic. You may not realize it, but if you've been working from home or using Zoom to chat with friends, you probably spend a lot of time in front of a microphone. So why not sound your best? Whether you're doing video conferencing, podcasting, recording music, or hosting a talk show, Blue has you covered. From the USB series that plugs right into your computer to XLR professional mics like the Mouse or the Blueberry we use in the studio right now. Bottom line, there's a Blue microphone to fit your budget and need. I can't say enough about Blue mics, and once you try one, you will never go back, trust me. To take your audio to the next level, go to drdrew.com/blue. That is drdrew.com/BLUE. Anyone who's watched me over the years knows that I'm obsessed with Hydrolyte. In my opinion, the best oral rehydration product on the market. I literally use it every day. My family uses it. When I had COVID, I'm telling you, Hydrolyte contributed to my recovery, kept me hydrated. Now, with things finally reopening back around the country, the potential exposure to the common cold is always around. And like always, Hydrolyte has got your back. Hydrolyte Plus Immunity, my new favorite, starts with their fast-absorbing electrolytes and adds a host of great ingredients. Plus, each single serving easy pour drink mix contains 1,000 milligrams of vitamin C, 300 milligrams of elderberry extract. Hydrolyte Plus Immunity comes in convenient, easy to pour sticks that rapidly dissolve in water, make a great tasting drink, has 75% less sugar than your typical sports drink. Uses all natural flavors, gluten-free, dairy-free, caffeine-free, non-GMO, and even vegan. Hydrolyte Plus Immunity is also now available in ready-to-drink bottles at the Walmart next to the pharmacy. Or as always, you can find it by visiting hydrolyte.com/drdrew. Again, that is hydrolyte.com/drdrew. Be sure to use the code DrDrew25 for a special discount. Here with my daughter Paulina to share an exciting new project. Over the years, we've talked to a ton of young people about what they really want to know about relationships.
It's difficult to know who you are and what you want, especially as a teenager. And not everyone has access to an expert in their house like I did. Of course, it wasn't like I was always that receptive to that advice.
Right, no kidding.
But now we have written the book on consent. It is called It Doesn't Have to Be Awkward, and it explores relationships, romantic relationships, and sex.
It's a great guide for teens, parents, and educators to go beyond the talk and have honest and meaningful conversations. It Doesn't Have to Be Awkward will be on sale September 21st.
You can order your book anywhere books are sold. Amazon, Barnes & Noble, Target, and of course your independent local bookstore. Links are available on drdrew.com.
So pre-ordering the book will help people, raise awareness, obviously, and it'll get that conversation going early so more people can notice this and spread the word of positivity about healthy relationships. So if you can, we would love your support by pre-ordering now.
Totally. And as we said before, this is a book that both teenagers and their parents should read.
Read the book, have the conversation. It Doesn't Have to Be Awkward, on sale September 21st. All right, we are back with Dr. Yo, Dr. Patterson, and Dr. Osgood. Dr. Osgood, back to you for a second, if you don't mind. This is all very interesting physiology, and I'm guessing as a hospitalist, it has sort of informed and changed some of your approaches to COVID.
Yeah, definitely. Pretty early on, we started giving statins to most of our inpatients, and we saw pretty clear signals this was helping. Pretty early on, we were actually giving methylprednisolone as our steroid of choice. We were doing really D-dimer targeted full dose anticoagulation early on. Really, some of the intuitions we had early on were pretty vindicated. Some of the other things did not, necessarily turn out to be borne out by the best evidence. But I think overall, our protocols have been good. But really giving your attention to each individual patient, treating them individually, following biomarkers as well as their clinical status has really been the most successful approach. Want to take a quick shout out and just give some recognition to the unsung heroes of the pandemic in the hospital, the medical residents. And I've been privileged to be part of a teaching program with some excellent medical residents, without whom we really could not have accomplished what we did during the waves of the pandemic.
It's interesting. I, as somebody who did my residency during the darkest hours of the AIDS epidemic, it's interesting how these disease-specific, well, they're pandemics, affect our training and our outlook going forward. In HIV and AIDS, oh my goodness. I mean, that was such a, we were in a war with that illness, and people were literally being torn apart by it, and just struggling to come up with something. It was like being a surgeon at the turn of the 20th century with only limited things to be able to do, and just struggling to find stuff.
Yeah, it's quite a time to be in training, really.
Yeah, it is. I hope it gives them a sense of desire to be very careful in their thinking and to be research oriented in their practice, and to be able to improvise and use their judgment in situations where things look rough. I mean, a lot of what we've done has been the result of improvisation. I mean, Dr. Yo and Dr. Patterson had some ideas about how this might work and started applying it, and lo and behold, it did. I mean, if you hadn't tried these things, this is the part about this pandemic that I have found astonishing, that people have been unwilling to try things that might work, that were based on good hypothesis, good physiology. Yeah. And you guys did, Bruce.
Yeah. Well, you know what? It wasn't easy, and it's still not easy. I mean, I've talked to, like I said, a number of hospitals and listen, hospitalists and intensivists, they're under the gun, and it's unbelievable what they're doing. But part of it is they don't have time to think about what you're proposing and what or think about it mechanistically, and and what they don't realize is that, for instance, if you used our severity score in acute patients, and you had a reasonable turnaround time of, say, a day to get your results, not only would that allow you to manage the patient better, but it will allow you to manage your resources. What they're not recognizing is when you don't know where the patient is on this immunologic continuum, you have no idea what the prognosis is. You don't know where they are immunologically in the cytokine storm or on either edge of the cytokine storm. And the problem is they're thinking about, the next patient who is coming through the ER who is just as sick and needs a bed. And I get that. I completely get that. But we have, what I insist to them is that you have to take care of that patient right in front of you right now. And you need to do the best possible job on that patient. I know there's patients waiting. Of course there are. But, and it's hard. I mean, sometimes they have to make difficult decisions about who gets resources and who doesn't get resources, especially in, I would say, February 2020, when I was collaborating with physicians in New York City and doing some of our initial studies on acute COVID. They had to decide who gets dialysis and who doesn't get dialysis, because the early COVID was really affecting kidney function and multi-organ function, for that matter. But the fact is, what they really need, and I've been talking about this, I spoke about this at the International COVID Summit, is you need to correct the immune system and time. The problem is and I just read an article that mimicked some of our early patients in 2020, where a patient was intubated and they were just about literally minutes away from pulling the plug, and all of a sudden came to. And, a few days later was out of the hospital. You know what? There's never been a disease like this. And I saw that a lot when we were using CCR5 antagonists under EIND in the February-March 2020 timeframe, where you could get them home. You could get them off ventilators. You could get them off ECMO. Got 5 patients off, which is basically, lung bypass, right? But what they were given, the ones that did leave, was time. And you corrected their immune system with the CCR5 antagonists, and they needed time. And in fact, ECMO was great because it gave their lungs, didn't have to do their normal jobs. All they had to do was repair themselves, right? Or allow, the inflammation to subside and allow the recovery to happen. The problem is we don't have the luxury of time when there's just masses of people flooding the ER. And I get that, but that demands a different approach. And if that approach is restore the immune system to normal as quickly as possible, then that's what has to be done. There's a time element here. And then also something like a severity score that can tell you where you are and how to manage those resources. There's some people in the severity score who were clinically severe, whose immune systems were almost normal. You could put them step down from the ICU, okay? Or conversely, someone with mild to moderate clinical symptoms who had a completely disastrous severity score and immune system that was very stormish, probably needed a step up. But that's how you could manage resources better while doing what's best for the patient.
It's very difficult to try to...
Go ahead, finish, Eric, please. Finish your thought.
I was going to say, when someone is in the process of crashing and you're worried about PPE and you're worried about, gowning up and all that, it gets very difficult. So being able to stay one step ahead, it would be incredibly valuable. And Dr. Drew, one thing you mentioned, I really wanted to kind of expand upon. You mentioned kind of the rigidity of clinical thinking during the pandemic, and nobody thinks that it's appropriate to do anything until, flawless randomized trials sort of spoon feed us conclusions about drugs. We seem to have forgotten that, the majority of clinical practice guidelines come from very imperfect studies. There's different grades and strength of clinical recommendations. A lot of what we do, especially in infectious disease and hospital management, are based sometimes on retrospective studies, sometimes cohort studies. And it's been a shame to see this kind of new zeitgeist of this just incredibly rigid protocolized approach to medicine.
It's unbelievable. It's the biggest shock to me of this entire pandemic. It's absolutely shocking. And I've witnessed firsthand a massive difference between those of us on the medical side versus the surgeons. The surgeons improvise. The shit goes down in the surgical field. They got to figure it out, not wait for a randomized controlled study. And early on, my surgical colleagues were trying all kinds of stuff. That's where I learned about things and how things were happening. The internal medicine side froze in place. I think it's because a lot of people are employees and or have clinical pathways in their hospitals that they're required to follow. That's a catastrophe. People want us to use our judgment. That's why you see a doctor. You don't need a doctor if you're just following a protocol. You don't need us.
Right.
Just tell somebody else do that. We're trained to use our judgment. When you don't know what to do, that's exactly where you want somebody making decisions that are improvisational. That's just what you got to do.
The public is counting on us.
I don't know. That's shocking to me. Shocking to me. It was disgusting and shocking. Bruce?
As long as we're still following the do no harm, mantra that we all carry. It's why not be innovative? That's the hallmark of everything that we do in life is to be creative, to be innovative. That's why we became doctors. But to be just a USB drive and being plugged into some system is, for me, when the book is written about this pandemic, for me, that's going to be my last chapter, is that, despite the creativity, despite innovation, you weren't allowed to be creative and innovative, and that's with FDA drugs that have a file on them on their safety, and you can't repurpose them because it's not in some protocol that, like Eric said, that's been in some massive, randomized control study where you don't get results for 18 months. How does that help you with your current surge in cases?
Yeah.
I mean,
yeah. Listen, we Hollywood and the public valorized the Dallas Buyers Clubs. What do you think they were doing? They were just improvising, trying stuff. Now, the part of the story they didn't tell in the movie is they got in the way of actual treatment ultimately. And I had a ton of patients die because of Dallas Buyers Club, but we were supportive of them when there was nothing else to be done. People were trying things, try something, try stuff. Yeah. And this pandemic, the exact opposite. I hope you will name that final chapter the biggest shock of the pandemic. What shocked me the most was our behavior in this. Ram, I was starting to ask you something. What the hell was I getting into for you? Could you tell where I was going? No, you couldn't tell.
Dr. Drew, there's something actually I want to mention, and I think it really maybe ties everything together, because you and Bruce and Eric were discussing about acute COVID, and obviously a little shift from long COVID. They kind of, there's a lot of things that we're picking up with long haulers and long COVID that I think really can, ties in a little bit with the acute phase of the disease. And one of the things, we're seeing is this immune dysfunction in a good majority of the patients. And it goes to the first question you asked, one of the earlier questions you posed was, do we have a consensus or a definition? Mm-hmm. And even now, look, some people call it long haulers, long COVID, chronic COVID, PAXE.
I know.
When we don't even have a consensus on what the pathology is.
Or whether it exists. There are people that insist that it doesn't exist, which I'm here to tell you as a long hauler, it exists. It's very unpleasant.
So when there's still a discussion, we're still trying to define everything. And what Dr. Patterson and our group have done is really identify that immune dysfunction. But that does not mean that this is the end all be all. Right. This is the word of God.
Right.
Clinical medicine doesn't work that way.
No.
And one of the interesting things that I'm sort of picking up, and like I said, this is from looking at over 2,000 patients now, is there's a certain percentage, I think it's probably anywhere from like 10 to 20% of quote unquote long haulers, they're probably not dealing with an immune dysfunction. These are patients, I just personally think, they had some damage done during the acute phase of the infection.
Yeah.
These are ones that, whether it's neurological, respiratory, cardiac, or one of the other systems in the body, the acute phase of the virus or of the disease caused destruction. Yeah. So we're talking about something a little bit different than the immune dysfunction. Now, a good majority, though, of the long haul, I would probably say like 70, 80%, are what we've discovered with that immune dysfunction and the S1 protein and whatnot. And that goes back to the clinical management and exactly what Eric or Dr. Osgood was talking about with the clinical design. If you enroll those patients that had acute destruction and don't have an immune dysfunction, the trial is going to fail. Maraviroc and statin are not going to work for them, or any of these therapeutics that we're sort of looking at. Right. Because for them, there's something else that's going on. Anyone in clinical medicine that says they have 100% success rate should be selling used cars. So, so what this is allowing us to do, this clinical insight we have, is to really start to understand the pathology. So you got this certain group of patients that, and I say this, and I'll bring up one particular case. I'll try to keep it as general as possible. This is a young woman that definitely had an acute case, definitely had COVID, very mild case of COVID, started to develop neurological symptoms, back pain and really severe headache and migraines while she had COVID. This was about day 3 of infection.
Mm-hmm. Very common, by the way. That's a very common symptom, yeah.
She then started to develop, she said like after she got over this acute phase of COVID, she started, it just persisted. And we looked at her cytokine panel. She was normal. She was on a clinical trial with another medication, didn't respond. We had her on Maraviroc, ivermectin, statins, colchicine, you name it, she got it. For weeks and weeks and weeks and weeks. Immune profile was always normal. S1 came back negative. What exactly is going on? We work, and this is the other thing people always think about what, Dr. Patterson, me, and the rest of our team, they just think it's like Maraviroc or bust. Like that's all these guys. We're interacting with hundreds and hundreds of physicians in the United States. and now globally. And again, it's what you told me several months ago. It's about physicians don't talk to each other. And I always tell you, Dr. Drew, I took it to heart.
Good.
And they really have implemented that, where it's a close collaboration, and we're working with different researchers. But we had this patient work with a neurologist who's got a lot of experience with ME/CFS and a lot of chronic illnesses. And there's a test called a neuroquant, and it actually measures sort of the brain volumes. And it's almost like an MRI. I'm not too familiar with it, but she had this patient who's a young woman, she's 28 years old. We had a neuroquant, her brain scan, and she shared these results with Dr. Patterson and myself. She looked like an early Alzheimer's patient.
Yeah, I'm not surprised. I've seen other illnesses do something like this, and I've always thought it was vascular related. So it's literally, a lot of it's glial cell dropout, but it comes back, but it can also be irreversible.
We're hoping, and then it's a question of what.
What's that, Bruce?
We looked at with Dr. Lalazari and his father, Dr. Lalazari. We did a pilot study in Alzheimer's where we took brain homogenates and ran our 150 biomarker panel and found that interleukin 18 divided by interleukin 4 actually told you if you were mild Alzheimer's or severe. So the inflammatory component of Alzheimer's is very predictive and very interesting, and it's truly a part of the pathogenesis.
Interesting. That makes perfect sense to me. I've never thought the plaques had anything but sort of incidental or consequential sort of, it's like looking at gliosis and saying the scar is the problem. It's like, I'm not so sure. Ram, I remember what I wanted to ask you. How's your friend, the anesthesiologist that I spoke to, doing?
Tom's doing well. In fact, as Dr. Patterson sort of mentioned about, someone is actually writing our story. It'll be several months, and it's not about us. It's really about the whole program and how all these amazing people and how we're slowly transforming medicine. And Tom is doing well. Actually just sent him a text message because his story kind of is the reason why I ended up, meeting Bruce and really looking at this and from the whole acute phase of the COVID. He's doing wonderful. I'm really excited to say that he, I don't want to say he made a full recovery, but he's about 90% of where he was. Still has a little bit of a foot drop, and but again, from where he was, 51 days in an ICU to where he is now, is pretty remarkable. But Tom was so instrumental. I think just changed the trajectory of my life. If it weren't for him and him unfortunately getting sick, I would never have met Bruce.
Isn't that incredible?
I would never have had all these brainstorming sessions for several months and formed COVIDlonghaulers.com. The whole concept would never have started. It's I can't even put it into words how how that changed my life, but it changed all of us. I mean, changed Dr. Pat. I think he would probably agree. Like Dr. Patterson's life changed Eric. Everyone.
Well, by the way, for me,
Kramer, Bream,
it's all the stuff I've been complaining about for the last 20 minutes, but it's been the one bright spot in terms of, for me, physicians doing the right thing, doing what we're supposed to do, what we know how to do well as scientists. I have to wrap up pretty soon. I have a couple of random questions. Somebody was asking, given that vascular dilatation is a feature of the monocyte function, can not my brain, this is my COVID brain, the PDF5 inhibitors, the things like Viagra or Cialis, are those inadvisable in post-COVID? PDE5.
Well, again,
PDE5.
You have to be careful with something that dilates blood vessels, and people, they have temperature, insensitivity, both hot and cold. And they're like, oh, my fingers are numb and my toes are numb, or they're swollen. Everything's always swollen. Well, all of that is vascular dilatation. So, I'd be careful with them while you have long COVID. Like exercise, we can bring them along slowly. And I never say never. We'll get them there at some point, but let's take care of what's causing the bad vasodilatation.
Right. And I think I also have a fantasy that as a result of all your guys' research that we're going to learn about how tremendously different the cerebral vasculature is, or the endothelium is in the cerebral vasculature. I've always kind of thought that. And I bet you're going to uncover a lot of interesting, unique qualities in the cerebral vasculature. You agree with that?
Yeah, I think we're going to learn a lot about
there we are, Bruce.
The effects of the blood-brain barrier in these conditions. Right. Yeah, that maybe it may be just permeable as well. So we'll see.
Susan, I've lost my image of my friends here. I hope it's not. I hope that's not what's going out.
We're good.
Okay, gentlemen, I got to kind of wrap this thing up. I could. This is nerding out for me. I could kind of keep going. I can think of a lot of other things I'm interested in. One last thing. Fluvoxamine was something on the radar last time we spoke. Is that just off now? It seemed to have helped me quite a bit. Somebody already on a statin. Curious.
We're using a lot of it.
A lot of it still, yeah. So that Sigma 1 system is a feature of all this. Interesting.
Yeah, as you see,
how long? Just Eric, how long do you keep people on it?
Again, we really let the clinical course drive. We don't really necessarily have any hard endpoints. We start to taper people off when we feel like they're ready. And generally, people do not want to be, people are not big fans of polypharmacy. These are a lot of patients who have never been on a medicine, no past medical history. They want to get back to their lives. They don't want to be taking medication. But if you withdraw the therapy too soon, they can rebound. So we really keep a close eye on the biomarkers, and we keep a close eye on the clinical progress. And when it's time to start tapering, we do it. So there's really no one size fits all.
I was really asking about what pertained to fluvoxamine as it pertains to the inflammation of the brain, and we were talking about Alzheimer's and the inflammatory component of Alzheimer's, and whether we're going to see some dementias down the road from COVID, and maybe some longer. I've been ruminating whether or not a longer term fluvoxamine on a low dose would be something smart in people that have a long hauler. That's a very, very, very distinct question. I know you guys aren't looking at that, but any thoughts?
I push long-term, statin use and I'm also pushing statins for people when they get the vaccines, because I think it's a non-immunosuppressive way to just add a little bit of extra protection, to the blood vessels if needed.
Interesting. And finally, my last question, Bruce, any thoughts on the risk to pediatric populations? Does anything keep you up at night there? We can't really give them statins.
You can. So we are seeing a lot of pediatric, and both there's great studies on Maraviroc in the pediatric population, which makes it unique amongst CCR5 antagonists, and also atorvastatin has been shown in clinical studies to be safe for use in kids. So, yeah, and indeed, we are seeing a huge uptick in the number of kids with long COVID or PASC.
Yeah. Gentlemen, thank you so much first of all, for joining us, and more importantly, for all the work and the diligence and the ongoing work. And Eric, it's such a privilege to talk to you and to know you're part of this team. I agree with Bruce that your addition is exactly what the kind of what the doctor ordered, so to speak. And I just look forward to. I mean, so much has changed since the last time we spoke. It's really kind of interesting. The last time we spoke, you were sort of saying, "Well, we found these S1 proteins in these classical, non-classical monocytes, and we think that might have something to do with something." And then you were sort of. We were also talking about CCR5 antagonists, and you were like, I just got a hunch there's something going on there. And I can't really say it yet, but we think there's something. This is a lot different now, and I'm sure it'll be different next time we speak. So please do keep it up, gentlemen. And thank you for joining us. I appreciate it so much.
Thank you. It's a pleasure.
Thank you so much.
Thank you, guys. And Ram, you're still there on Clubhouse. I'll say goodbye to you. Thank you for bringing these guys to me, and as always, being such an important driving force in all this.
Thanks, Dr. Drew. Thanks to you and Susan and the rest of your team for, the support that, that you provided us, but I think most importantly, the support and a lot of the advocacy you've done on behalf of the patients, the long COVID patients having post-vax issues, many other chronic illnesses and pathology. So I'm very grateful for your support, you and Susan, all the work that you're doing, and thank you very much.
We're doing the light lifting. You're doing the heavy lifting, and we appreciate it. So, Ram, I'm going to end the Clubhouse room. Thank you guys there, and thank you, Ram, and thank you everyone who patiently listened to us. And for those of you out there, tomorrow we have Dr. Lucy McBride, and Dr. McBride is a Harvard-trained physician who has been publishing she's been doing with a newsletter what I've been trying to do with this streaming show. And she's smart. She's got a lot of interesting ideas. I just want to pick her brain a little bit. We have Dr. Bhattacharya in here on Wednesday. You know him well. He's been on this show before. Again, another brilliant person. Alex Berenson, who is the eternal gadfly to the COVID sort of response, the COVID response. And then on Tuesday, that's on Monday, Alex. Then on Tuesday, Dr. Vinay Prasad. I was listening to his podcast. His last four podcasts have been on fire. Oh my goodness, I recommend them so highly. And his latest one is talking to a virologist, vaccine expert, about vaccines in kids and the things they're worrying about, and having an honest discussion about this. And these last 4 weeks have been the best sources on where we've gone wrong, what our concerns are to be, how monolithic our thinking has been, and the kinds of trouble we're likely to get into as a result. So we got a lot of really good people coming up, and we're all heading into Thanksgiving. So we will let you go across the Thanksgiving holiday, but we have Lucy McBride tomorrow and Bhattacharya on Wednesday. And Susan, anything going on with you?
Nope.
I got to share with the Restream people and the Locals people. We were on a local stream before we heated up here with the streaming show, and I told them they were all very much impressed with Your Mom's House Live on Friday night. And I told them that you nearly threw up in the car. We were playing it in the car, and Susan had to do everything in her power not to vomit. I'll be talking about that more on After Dark, because there was a lot of hysterical corollaries I want to save for the boys. And Christina, if I can get her in there too, because they were the source of the extreme.
You found it funny.
I was
horrified.
I realized that's why Tom invented this thing, was to torment his wife. I think that's what this was all about. But that was a particularly tormentful live YMH Live.
Well, we were driving for an hour and a half from Pasadena Laguna.
Yeah.
And I said, "Oh, I paid for it. Let's
watch it. Let's go. Let's watch my live." And I thank God I was driving, so I didn't have to look at it. I glanced once in a while.
I love that Christina was throwing up. She had to throw up too.
Yes. And that's
I think Tom did too.
Tom will start to lose it all of a sudden. But I really think it's to torment his wife. That's why he started this out.
God.
Yeah. Susan was particularly. Was it the brown or the vomit, or which one got you the most?
Do I have to talk about it?
Yeah.
It's so
that's why I said this was this all about.
I can't really talk about it here, right? I can't say what happened. We'll get canceled.
Okay, but was it? People were the Locals folks wanted to know: was it the brown? Was it the vomit? Probably the brown. Right?
A lot of the
brown,
the combo,
yeah, I got you.
The vomit and brown.
If you don't know what we're talking about, it's Your Mom's House, where I have a show.
There's a lot of it.
Have a show called Doctor After Dark.
We needed some jokes in between.
Let's just say it as a very.
She kept going. She's going so soon. Caleb, quit dicking around with the thing. It's on the second screen, okay?
I'm trying to fix it.
He's trying to bring. It's over on the second screen now.
Don't worry about it. I'm fine. I'm fine.
Okay, good.
I'm going to wrap up anyway. But I just want to say that I
accidentally hit a button somehow, and the screen went away, and he's been moving it around, so that's why
it's okay. All I see is have a conversation.
But, I know. Well, I'm trying to change the subject.
But bottom line is,
I didn't realize how disgusting. Was that actually live in front of an audience?
Yeah. Oh no, it was live in front of a live audience.
Because I know they've done them live.
No, that's different. That's very different. Yeah, that's Your Mom's House.
I didn't think so.
In a theater.
I love how Joe started out with, "Oh, I can't believe you guys do this," and he goes, "I'm so proud of you, though."
Yeah, Joe Rogan.
For making making this your thing.
Right. It was very funny, and then he got into it. Joe? But the bottom line is very different emphasis than the time you've just spent with me. Very, very different.
Oh, 100%.
That's sort of what I like about all these different things I do. They're very, very different 180, environments.
Yeah, definitely.
Corolla and I are different. The one I do by myself over there is different. This one is different. After Dark is different. They have different sort of Cultures and qualities. Let's just. All right, let's wrap this thing up. I will see you tomorrow. Tomorrow and Wednesday are at 3 o'clock.
They don't put those ones on your show.
3 o'clock.
Really,
the next 4 at 3 o'clock Pacific time. So we'll see you tomorrow at 3 o'clock with Dr. Lucy McBride. See you then. What did I hear somebody say the other day? They go, "I love my husband, even though I want to tear his eyeballs out a lot of the time."
Oh yeah.
And I thought, but normally they wouldn't say it quite that violently. You know what I mean? I thought it caught my ear. I was like, "Oh, this is interesting. There's more explicit violence," which I don't mind as a sub.
It is. You've got your harness on under that. I wish you took your shirt off when there was like your bondage gear.
I had a bunch of nipple rings with leather.
Jeez, this is a whole new lane for you.
Ask Dr. Drew is produced by Caleb Nation and Susan Pinsky. As a reminder, the discussions here are not a substitute for medical care, diagnosis, or treatment. This show is intended for educational and informational purposes only. I am a licensed physician, but I am not a replacement for your personal doctor, and I'm not practicing medicine here. Always remember that our understanding of medicine and science is constantly evolving. Though my opinion is based on the information that is available to me today, some of the contents of this show could be outdated in the future. Be sure to check with trusted resources in case any of the information has been updated since this was published. If you or someone you know is in immediate danger, don't call me, call 911. If you're feeling hopeless or suicidal, call the National Suicide Prevention Lifeline at 800-273-8255. You can find more of my recommended organizations and helpful resources at drdrew.com/help.